Hello, everybody. Welcome to Endoscopy Now and today's virtual education event on the new guidelines for endoscopic tattooing presented by Dr. I'm Jimena Garcia Vela, Vice President of Marketing at GI Supply, and I'll be your moderator for today's event. This presentation is being recorded in its entirety, and a replay will be available on the Endoscopy Now app within a few days. During the event, if you have any questions or comments, please submit them using the chat box at the bottom of your viewing screen. All questions will be addressed at the end of the presentation. Finally, with so many people on the internet and the varying degrees of signal strength and bandwidth at your location, you may experience some interference. If you happen to get bumped off the live session, please sign back in. And if you continue to have trouble with your connection, please try to relocate to a space near a window or a place with a stronger Wi-Fi and data connection. And with that, we're honored to present today's speaker, Dr. Douglas Rex. Dr. Rex is the Director of Endoscopy at Indiana University Hospital in Indianapolis. He's Distinguished Professor Emeritus of Medicine at Indiana University School of Medicine and the Counselor Professor of Purdue University in Indianapolis. Welcome, Dr. Rex, and thank you for taking time to join us today. The floor is yours.
Thank you, Jimena, and hi, everybody. So we're going to have a clinical discussion about tattooing, and we'll be mentioning some of the new guidelines. These are my disclosures. The newest guideline about resection comes from the Multi-Society Task Force. If you're not familiar with it, the Multi-Society Task Force is formed from the 3 GI societies, the ACG, the ASGE, and the AGA. And my colleague, Tanya Kaltenbach, is the first author on this paper. It's a general discussion of resection techniques and principles in the colorectum, and it does make recommendations about tattooing, and that's what we're going to explore in more depth. So there are 2 primary reasons that we tattoo or mark the colon during colonoscopy. And the first one is for surgical localization. So if you look at this photograph in the upper right, you can see a surgeon's hand on the colon and a dark black tattoo that is visible on the surface. And this sort of gets at a lot of the important points to make are sort of wound up in this single photograph. So the purpose overall of localizing lesions in the colon for surgery is to avoid taking out the wrong section. We call that wrong site surgery. And wrong site surgery can be problematic. It can be the basis of a medical malpractice suit, and it could potentially result in symptoms or complications. And so we are marking things in order to make sure that the correct section is taken out. And so when we do tattooing correctly, that is, we put the tattoo into the submucosal space, that's the correct place to put it, it's going to be visible to the surgeon visually from the serosal surface. They can see that tattoo through the serosa and the muscularis propria in the submucosa. I sometimes hear, and I've been involved in malpractice actions and read depositions. I see people think that it's being injected into the muscularis propria. It's not really. That you can get tattoo into the muscularis propria, but the correct place to put it is in the submucosa, and it's very visible there. And we like to avoid spilling it all over. We like to avoid injecting it into the omentum or the kidney or some other organ and keep it in the wall of the bowel. Now, I'm not a surgeon. I'm a gastroenterologist, but of course I work with surgeons, and we've got to be on the same page and speaking the same language. The basic principle of localization for surgery is that I'm going to mark something that I'm not 100% sure where it is. So a fundamental principle is that if you can't see the cecum or the ileocecal valve, if it's disappeared from view, or if you're not in the rectum or perhaps the distal sigmoid, then you should, as a principle, say that you've got some uncertainty about where you are in the colon. And so the purpose of tattooing is to convey that you don't know for sure, and the surgeon has to find the tattoo. Now, sometimes there'll be tattoo that is spilled around the peritoneal cavity. It may be lying on the surface of the colon. And as I said, it could be in another organ. It's critical that the surgeon and you are on the same wavelength, that your expectation is that they are going to find that tattoo. Now, this is an open operation there, but of course, in laparoscopic surgery, then really the only way to find the correct segment, because the surgeon, if it's a cancer, they can't feel it with their hand by palpating the colon. It's critical that they be able to see the tattoo. But the most important thing is that if they can't find the tattoo, then they need to do intraoperative colonoscopy. They either need to call you to come to the operating room, or they need to do intraoperative colonoscopy themselves in order to locate the lesion. But sort of seeing the tattoo, on the left side in the omentum is not a rationale for taking out the descending colon, for example. So we've got to be on the same wavelength that this view right here of the serosal surface showing the tattoo on the colon wall, that is what we're looking for. The second reason is endoscopic surveillance, and we're going to come back to that. This is a study that compares a fairly small group of patients. It's not a randomized trial in two different time periods, those who were not tattooed to those who were tattooed, and shows two of the basic sort of advantages of tattooing from the perspective of surgery. One is that, if the tattoo is made correctly, you should be able to find the tattoo, the correct localization in basically about every case. And the other one is that because you can do that quickly and there's a level of reassurance about it, it shortens the operative time. So it's got some advantages and cost advantages even from the perspective of shortening operating time. This is a study that looked at a large number of studies, 38. It's kind of a meta-analysis / review, a large group of patients who underwent conventional colonoscopy, and then another group of patients who underwent tattooing. And it looks at the rate of localization errors. And you can see the definition of that is the tumor is in a different segment from what was preoperatively stated. Now I'll come back to that, but that's part of that basic principle, is that when you tattoo something, you're saying that I don't know for sure what segment it's in. And one always needs to have a certain amount of caution about saying how specifically you are saying that this tumor or other lesion that you think needs to be operated is in, for example, the descending colon or the transverse colon. We kind of want to get away from designating the segment if we can't see the cecum or the ileocecal valve, because we want the surgeon to find the tattoo. We don't want to leave a situation where we've said, I put the tattoo on, the tumor's in the descending colon, and they get in there, they can't find the tattoo, but you said it was in the descending colon, so they take out the descending colon. That turns out to be the wrong section. So we're gonna have a certain vagueness about ever making this kind of possible error that the tumor is in something that we specified by being a little bit less specific. Or they can't localize it, or they need to do an intraoperative colonoscopy, or they end up having to convert to open to find it because they need to palpate along the bowel in order to find it. These were localization errors, and you can see 15.4% versus 9.5%. So tattooing clearly helps when you survey the literature. Now, the one thing that comes to my mind in looking at this study is, well, 9.5% of the time the tattoo didn't work. And why is that? And I think, again, it often comes down to, are there technical errors in the way that the tattoo is applied? Was enough tattoo put in to the submucosal space in order to identify the lesion? So we do have some evidence that tattooing improves surgical outcomes. I already mentioned the shorter operative times, accurate trocar placement, reducing the conversion to open procedures, fewer positive margins. I like to just tattoo at one end of tumors. I usually tattoo at the distal end. Before I forget it, I should say that, you know, one of the principles that has come out recently is that when we diagnose a tumor, I had a case of this just this morning, where a patient had been referred for a previous incomplete colonoscopy after a positive Cologuard. And when I got over to the right colon, there was a cancer in the colon, and you know, there were a couple of polyps that were maybe 5 or 10 centimeters distal. So I took those out first and then tattooed the lesion. And the last thing I did was to biopsy the lesion. So usually I'll place the tattoos distal, and then you just want to say in the report where you put them in relationship to the lesion. I think it's a mistake to tattoo both proximally and distally. It's much more straightforward to put in one ring of tattoos and then say where it is in the report. But clearly fewer positive margins because the surgeon knows where to do the transection, and then reduced wrong site surgery. And that's what we're after. Now, I will say that one of the things that I think is increasingly the case, and I'm going to show a slide on this in a minute, the other extreme of this is that not enough lesions are getting tattooed. The other extreme of that is that there are a fair number of patients now that are floating around with multiple tattoos in the colon. So when you find a lesion that you think needs to be removed surgically, and the patient has other tattoos from previous colonoscopies, you've got now to try to convey that to your surgical colleague and make sure that they understand somehow, in the context of, if they get in there and they see multiple tattoos, how are they going to find the right one? And this could require whatever steps you think are necessary, matching it up to CT findings if it's a tumor and the tumor is visible on the CT, doing something extra to make sure that they're seeing the right tattoos. So we see the full spectrum of things, from lesions not being tattooed at all, too little tattooing, and individual patients who've got multiple tattoos, and that needs a lot of communication also. Okay, so this is a study from Northwestern that looked at a 17-year period, 611 patients, and the frequency of tattoos, and you can see that of lesions that they felt probably should be tattooed, that about half of them were actually tattooed. So there's probably an underuse of tattooing over the past couple of decades. Now, the other reason that we tattoo is for endoscopic follow-up. And if you look at this picture, what you're looking at is a scar after an endoscopic mucosal resection. The two little bumps that are visible on either side of that scar. On the left side, you see a number of sort of thick folds, and then between a couple of these folds, there is a bump on the left, and there's a little bump on the right. That's not actually a residual polyp. That's what we call clip artifact. And right now, we've got some evidence that when we do EMR, if we put clips on prophylactically, we can reduce the risk of bleeding from large EMR sites where electrocautery was used that are in the proximal colon. So this is a clip artifact, and you can see the tattoo on this lesion is off to the right. I think that finding scars at follow-up is a little bit of an art. This one would be easy because it's a big, broad scar, but a lot of them are fairly linear. I think scars are best seen when the colon is very well distended and in white light. If you're underwater, it's hard to see scars. If the colon is at all collapsed, it's hard to see them. I think it's easier to see them in white light than narrow band. It's good to inspect them in narrow band once you've found them, but the first trick sometimes is to simply find them. And there, for that, you want a well-distended colon looking in white light, and that's kind of what brings out the contrast between the white scar. But that's a tattoo that was placed shortly after the EMR, and makes it easy to at least find the area where to look. So we know that tattooing is effective, and it's important for this because we have significant recurrence rates after piecemeal EMR. If you look at Chesire Hassan's big meta-analysis of recurrence rates after EMR, it's about 15% after piecemeal EMR of lesions over 20 millimeters in size. That compares to with ESD, where the recurrence rate is around 2%. So 15% is pretty significant. It's the major deficiency of EMR compared to ESD. And this study is a kind of a famous study. It's often referred to as the CARE study. It was done by Heiko Pohl at Dartmouth, and it looked at polyps that were under 20 millimeters in size and the frequency with which they were incompletely resected. And there were several important observations. One is that complete resection is operator dependent. So we see this now for so many things with colonoscopy. We know that detection is operator dependent. We also know that resection is operator dependent. In this study, the rates of incomplete resection varied about threefold between the most and the least effective resector. That's been seen subsequently in other studies, actually, including from Northwestern, about a threefold variation. And there's very little correlation between good detection and good resection. Some people are good at one and not the other. Some people are good at both. Some people are good at neither. Obviously, we want to be good at both. But this points out other risk factors, which are just size. 17.3% overall incomplete resection for lesions 10 millimeters or larger. And in this study, serrated lesions, I think now the best term for these is sessile serrated lesions, but some people call them sessile serrated adenomas or sessile serrated polyps. All of those terms are absolutely, completely synonymous. Sessile serrated lesion is kind of emerging as the most popular term, but in this study, using conventional resection techniques, serrated lesions were about 5 times as likely as adenomas of comparable size to be incompletely resected. Now, we know that for serrated lesions, when we use EMR, when we use contrast in the submucosa, and we have a high definition scope, that we can get the resection rates down low. So I think that particular problem has been solved, but it brings out the point that piecemeal EMR needs to be followed up. I actually, if I do a piecemeal EMR on a lesion under 20 millimeters in size, a lot of times I'll still bring the patient back in 3 years. Not everything that is piecemealed has to be brought back in 6 months. Our guidelines, the one I showed you earlier, says bring them back in 6 months if the thing is over 20 millimeters in size. Even in the 20 to 30 millimeter size range, I sometimes bring people back in a year. But the point is that lesions that are big enough to be piecemealed are going to need some follow-up. If there's any question about it, you may want to put in a tattoo to help localize it when you get back. So large polyps, which have a higher risk of recurrence and a higher risk of having cancer, these are important lesions to follow up. This lesion over on the left has a tattoo on the opposite wall. In the center is an adenoma in the process of piecemeal EMR. So for this 15% recurrence rate, we would want to put a tattoo in many of these lesions. And then lesions that are difficult to locate. Here's a lesion on the right that is about to be injected in retroflexion in the right colon. Some large serrated lesions that are difficult to see before they were removed. If there's a recurrence, it may be difficult to find. So these are all lesions that would be good to consider a tattoo for endoscopic surveillance. This is the original data with SPOT, which is the commercial agent that GI Supply makes, and which I think most of us have moved to rather than India Ink. The disadvantage of India Ink is that it contains a variety of immunologically active substances that can either induce complications like sterile abscess at the site or even outside of the bowel if it's injected outside the bowel. There's been a single report of it even inducing inflammatory bowel disease from the injection site in the proximal colon all the way down to the anus. So spot, which is pure carbon black, has been shown to be very reliable and for surgery and for endoscopic follow-up. And these tattoos are basically permanent. This is a study showing that these persist in the colon and are identifiable out to 7 years. There's another study in the literature showing cases that are out for 10 years. For all intents and purposes, of course, carbon black put into the submucosa is going to create a tattoo that is permanent. Are there times that we shouldn't use a tattoo? Well, I would say, first of all, that there's no point in tattooing anything in the cecum or on the ileocecal valve. And the reason for that is that they are basically their own landmarks. When I remove a lesion in that area, in the proximal right colon, I typically take a photograph of the lesion or of the EMR defect that shows the position of it in relationship to the ileocecal valve or to the appendiceal orifice. When the patient comes back for follow-up, I like to look at those photographs first so that I can go right to the scar site without having to search for it. But there's no point really in tattooing something where you've got a good anatomic landmark. The same may be true in the lower rectum. The other issue that comes up at times is tattooing, the timing of tattoo. I think there's several different times that we could tattoo a benign lesion. One of them is that you see the lesion and you say to yourself, I'm not going to remove this right now. Maybe you're in the ASC or the office and you want to remove it at the hospital. So you decide that you're going to tattoo it and remove it at a later date, or you're going to refer it to an interventional endoscopist. This is the situation where you want to keep the tattoo away from the lesion. And people often say at least 3 centimeters away. Usually only 1 tattoo is necessary in this situation. And, 3/4 or 1 ml is plenty of spot EX in order to be able to identify it. And then we're just going to say where it is. But we don't want to let the tattoo get under the lesion. And that's why we keep a distance away and not a wild amount of volume in that instance. There have been some reports in the literature that when tattoo gets under a lesion, that it sometimes induces fibrosis. I think that's particularly true if the injection is made right under it and gets into the muscle. I will say that I've seen an awful lot of tattoos under lesions, and for the most part, I have not personally found that there's a lot of fibrosis induced by it. But we should follow this rule of trying to keep the tattoo away from the lesion. Now, the other situation that comes up sometimes is that you're going to do an EMR yourself, and you're saying, why shouldn't I just put the tattoo right in the injection fluid, or just inject with spot? Maybe that question arises. And there, I think there has been the recommendation that, again, this could sort of create more fibrosis, that if you come back and there is a recurrence, that it could make it more difficult to remove it or complicate it. Now, in truth, the EMR itself is going to produce plenty of fibrosis when you come back if there's a recurrence. But I think that it probably makes sense to not put the tattoo in the submucosal injection fluid that you're going to use. Now, use to do an EMR. Now, once you've completed the EMR, then I usually will that's the third situation. First one is you found the lesion, you're going to tattoo it far away, remove it at a later date, or refer it to somebody else. Second one is you're doing the EMR, and now we're not going to put tattoo underneath it. Third one is I just removed it, and now I'm going to tattoo it so I can find the scar. At that point, I actually typically just put the tattoo fairly close to the EMR defect. I figure at that point that there's going to be plenty of scarring from the EMR itself, that the tattoo is not going to change things. So I think the timing makes a difference. Why do we do this? Well, we've already talked about it. If we put this tattoo on there, it's going to enable us to see this for a lifetime of procedures. We have to remember that the recurrence rate at the first follow-up after EMR of lesions 20 millimeters and larger, in the literature, it's about 15%. Even when the scar is normal at the first follow-up, we come back usually for a second follow-up. So we do our first follow-ups at about 6 months most of the time, sometimes at a year. And then we do the second follow-up usually at 18 months after the initial resection, 1 year after the 6-month follow-up. And at that point, even if the scar was completely normal at the first follow-up, there's still a recurrence rate of around 2 to 3% total. And so we still have to identify that scar, still have to make sure that it's clean at second follow-up. So we can do this very reliably, and we talk about the surgical advantages. On the left is the same scar with tattoo. On the right is a scar that hasn't been tattooed. And again, like I said, you want to get good distension to see scars. You get a polyposis patient, an SPS patient, you're going to be seeing scars all over the colon after a few colonoscopies if they have a substantial load of polyps. I don't necessarily tattoo all of those lesions, but especially the patient who has a few lesions or one big lesion can make it a lot easier to put a tattoo on. When we tattoo, there is some increased payment with regard to physician work RVUs. It's not a lot. The submucosal injection codes are usually used for this. There is an increase in the facility payment to both the ASC and the hospital when we do tattooing and use submucosal injection. Now, how to do it? Well, here are two lesions. This is a lesion on the left. You can see the tattoo is underneath it. This is actually a lesion that I removed basically en bloc. It's very close to the ileocecal valve and got a muscle injury. And the tattoo was clearly visible under the lesion. So maybe that tattoo increased the risk of getting that muscle injury. The other thing I'll say is that this lesion, which is probably about 20 millimeters across in its largest dimension or from top to bottom here, it's a bulky lesion. It's a 1S lesion. And it's often very tempting to remove lesions of this shape that are in the 2 to 3 centimeter size range en bloc. I think anytime that you are removing something with a big nodule in it, you're more likely to see muscle or cut muscle. So I don't really know whether the tattoo was an important factor in that particular injury, but it's just a reminder to try, if you're going to tattoo this kind of a lesion, keep that tattoo at least 3 centimeters away. Control the volume when you're marking it for a later resection. On the right is a sessile serrated lesion that has a dysplastic portion on the left part. On the left aspect of it, you can see that there's a section that has the nice 2 pattern. It has the Kudo 3L or 4 pattern. That's the dysplastic portion of an SSP that's extending off to the right. And you can see that there's a tattoo that's pretty much under most of this lesion. Now, I will say that this lesion did not have much fibrosis. It was relatively easily removed. If you talk about inducing fibrosis, the thing to not do here is to biopsy this lesion. If you biopsy any part of it, you are going to create fibrosis that's going to increase the need for avulsion and possibly some other technique to get rid of flat fibrotic type tissue. So if you ever see a lesion that you think doesn't have cancer in it, like neither one of these lesions do, if you feel compelled to take a biopsy some big fat bulky part of it. Don't biopsy the flat parts. You basically, any biopsy that you take from either the edge or the middle of a serrated lesion is going to tack that lesion down because they're all for the most part fairly flat. Now, here's an example of an incorrect tattoo placement. This is a lesion that is on the ileocecal valve. And this, again, I think is an example of, here you can see that the edge of the lesion on the distal edge of the valve. You can see some villi right along the valve. But the ileocecal valve itself is its own marker. So this is obviously, it's an adenoma. You can see the nice 2 pattern on it. And when we get a look at it here, you'll see that there's tattoo that's extending entirely around and underneath the lesion. But clearly you could just say to the referring doctor that here's a lesion that's on the distal edge of the ileocecal valve, and that would mark the lesion just fine. And here you can see the very dark stain of the black stain really of the submucosa when there's tattoo underneath it. Here we are finished up and we're doing some snare tip soft coagulation current to the edge of the lesion. This is now the standard approach to reducing the risk. So here is just an example of where it's really not necessary to place a tattoo. On the lesion on the left, the tattoo's on the opposite wall. I think that that's okay. On the lesion on the right, the tattoo is placed far off to the left, several centimeters away. Neither one of these had tattoo underneath them. The lesion on the left is dark underneath it because it's actually been lifted at the point that the photograph is taken. A lot of people think that you should standardize it in the institution, and actually some recommendations have been made to always place the tattoo on the same side of the polyp, about 3 to 4 centimeters distal. I think it's fine if you want to standardize it, but the most important thing is that after you place the tattoo, say in the report where you put it. I put it on the opposite wall of the lesion. I put it 3 centimeters distal on the same side. That language should be there. We recently reviewed a couple of hundred consecutive referrals over the last 6 or 8 months, and half the time it just says the lesion was tattooed, but it doesn't say the relationship of that tattoo to the lesion. Sometimes these patients have a lot of synchronous disease in their colon. So this can help the doctor that you're referring to be sure that they're dealing, that the lesion you say that you wanted removed is in fact the same one, so they know which one you really wanted removed, as opposed to one of the other lesions that they see in the colon. Here's a schematic of this. When we're marking for surgical resection, I like to mark distal to the site, usually in 3 or 4 quadrants. And then if you're marking for future EMR, place it on the same side as the lesion, but about 3 centimeters distal, or wherever you put it, keep it away from the lesion and say specifically in the report where you put it. If you are marking a lesion that you've just removed, then again, I would say where you put it. A lot of times I will put it into the bleb from the EMR. So, you've just finished the EMR and you've still got a fair amount of submucosal cushion from your injection. And so I'll just pick the easiest place, put the tattoo in there, and then I'll just say I usually say with the lesion down, the tattoo is just to the right or just distal. Because you remember, if you put the lesion up, it's going to be, and you're talking about right or left, it's going to be on the opposite side. So I'll say with the lesion down, the tattoo is immediately to the right or just distal. And again, you can consider having a policy about that in your group and with your surgeons if you can organize that. Now, what about the technique? So the entire point is to get the stuff into the submucosa. To be a sort of a clean tattooer, you want to get the tattoo into the submucosa, and the most reliable way to do that is the bleb technique. So the picture in the upper left is showing a clip that is on an EMR site that is just on the proximal side of a fold. You can't really see the EMR site here, and we're going to demonstrate the bleb technique. So the first step is to get the needle into the submucosa. And I think that the most reliable way to do this is to get tangential. The more en face you are to the wall, the harder it is. You want to deflate a little bit in most instances. That kind of thickens up the submucosa, makes it less likely that you're going to push the needle right through the wall. So tangential, a little bit of deflation, get the needle up, and then lift it up. And what you're seeing in figure A is actually the shape of the needle extending out from the catheter in the submucosa. And when you see that, that's very similar to the PPD technique that we use on the skin. And you know pretty much you're going to be in the submucosa. Now, some people just tattoo directly. And if you do tattoo directly without doing the bleb technique, figure A shows the entire key to doing it successfully. And that is approach tangentially rather than en face. And then once the needle is in the submucosa, or you think it might be, lift up and look for this deflection or shape of the needle in the submucosa. Then you can start the injection, make a bleb in B with saline, and then fill up the bleb with your tattoo. So here's a video of what the bleb technique looks like. Now, in this case, because we're tattooing for subsequent endoscopic follow-up, we're just going to tattoo on one wall. So we're poking a little bit, the lumen's kind of deflated, then we draw back on the needle and then lift it up toward the lumen. And there you can see that shape. Now we could, we'd probably get away with injecting the tattoo directly unless it shot out the other side. Sometimes you can't tell if it's going to shoot out the other side. But this bleb technique is very reliable. So we make the bleb, and now it's easy to get into the submucosa. So poke the needle back in, and then just withdraw a little bit, lift a little bit again, and now we can inject. I think actually in this case, we're just using the same catheter. Oftentimes you want to flush it, get the tattoo down the catheter. Now you can see it turning black where the tattoo is entering. And that's the old, so in this case, I would then put in the report, this lesion was injected just distally, and with the lesion down, looks like it would be slightly to the left because the lesion's a little bit off to the right. So that's the bleb technique, and documentation, very important. So it's okay to give an estimated location, but I usually will put language in there saying that I'm not sure. So for example, in the impression, I may say, this lesion was at 45 centimeters. It appears to be approximately in the area of the splenic flexure, but please locate the tattoo. If it's a big lesion and it's visible on the staging CT scans, that of course is going to make things easier too. I think that localization errors often occur more often when benign lesions are sent to surgery because there isn't any kind of CT guidance in more of those cases. Of course, very few of those cases should be going to surgery in the first place. We should be resecting those endoscopically and tattooing them for endoscopic follow-up. You do want to put in the amount that you placed, and then always say the location in relation to the lesion. Specify the relevant landmarks when you're not tattooing. So again, this is saying the lesion is between the appendiceal orifice and the ileocecal valve and the medial wall, or if you're using the cecal and ileocecal valve as your landmarks. Photograph after you put the tattoos in. Photograph the lesion with the tattoo or the EMR defect with the tattoo. So be thorough with both description and photography. So I think those are many of the clinically important relevant points about the use of tattooing in the colon. And I hope you've got some questions for me.
Thank you, Dr. Rex, for this informative presentation on endoscopic tattooing. We will now move to the Q&A portion. And if you haven't already done so, please submit your questions and comments using the chat box at the bottom of your screen. We already have gotten a few questions. So the first one is, approximately what volume do you use per injection site?
So the recommended volumes are typically 0.75 or 3/4 of an ml to an ml. I think especially when you're tattooing a lesion that you're going to remove later, you want to be a little careful about the volumes. The bigger the mound you make, the more it's going to spread out. Even though the mound only looks a centimeter or 1.5 centimeters, when you inject it, when you make the bleb, it's going to spread out over 2 to 3 centimeters. So keep the volume small there. So most of the time, 0.75 to 1 mLs. I think that a little more volume is sometimes appropriate when you're doing tattooing a tumor for surgery, especially in a patient who's very obese. They may have a lot more fat around the colon, and getting a little bit larger tattoo and a little bit more extensive tattoo may be helpful for localization surgically. But the standard amounts are 0.75 to 1 ml.
Great. Injection needle that you prefer to use when tattooing?
Not really. I think that either 23 or 25 gauge needles are fine to use. There are certain circumstances, if there's some fibrosis around, where a 25 gauge needle can be easier to get into the submucosa. I don't have a strong preference with regard to manufacturers. I think for the most part, either 23 or 25 gauge needles in normal bowel wall will work fine.
Awesome. Would you consider tattooing just distal to the tumor if the lesion is on the left colon?
Yes, I actually still prefer that so that there's no confusion. If you've got 2 rings of tattoos, then if only one of them is found during surgery, then there's always the issue of working hard to find the other one if it's been tattooed on both ends. I would rather have the surgeon just find the tattoo at one end of the lesion, and so I prefer to do it distally in all parts of the colon. Great.
Can you predict difficult locations that the surgeon cannot find the tattoo markings?
I think the most important thing, if you're putting in an adequate amount, is to consider, the body habitus of the patient. I think the hardest patients, from what I've been told by surgeons, to find them in are obese males who oftentimes have a very large amount of fat around the colon. And so in that situation, in the left colon, sometimes I'll put in, as I said, some extra to try to enhance it. I'll tell you honestly, following relatively standard techniques and putting in extra in that situation, I have not had a situation ever where I've had to be called to the OR to find a tattoo. So I think the keys are, from a technical standpoint, get into the submucosa. Make sure that you're in the submucosa as you're injecting, that you see a bleb form, and that you leave the area with a good amount of tattoo. I'm talking about for surgical localization, that you're confident is in the submucosa, and the surgeons will be able to find it.
Great. Let me give everybody one more second to see if they have additional questions. No, I think that this concludes today's presentation and Q&A. Thank you, Dr. Rex, for the presentation. This was great. And thank you, everybody, for joining us today. The replay will be available on the Endoscopy Now app within a few days, just in case you would like to revisit the information. Thank you, everybody, again, and enjoy your evening. Thank you.
Thank you.